This is Randall Schell, and I'm producing a Flip Classroom pre-session podcast on congenital heart disease and anesthesia, providing some foundational concepts. I've provided some suggested readings in Anesthesia in Children with Congenital Heart Disease by Elliot Crane, downloadable on the UK Wiki. Anesthesia for the Patient with Congenital Heart Disease in Current Opinion in Anesthesiology 2013, again downloadable on the UK Wiki, and Stolting's chapter on the topic of congenital heart disease. Let's look at the ABA IT keywords from 2006 to 2015 on the topic of congenital heart disease, and I've broken them down into 5 major topics: patent ductus arteriosus, tetralogy of Fallot, single ventricle or Fontan physiology, hypoplastic left heart, and some other miscellaneous topics. Under patent ductus arteriosus, many patients who have congenital heart disease may be dependent on an open ductus, and prostaglandins are used to keep the ductus open. Frequently, the ductus is ligated when it remains open after birth. And what are the circulatory effects of those, i.e. systolic and diastolic blood pressures? What happens if shortly after birth the ductus reopens or flow occurs across a patent foramen ovale, that is a persistent fetal circulation? Tetralogy of Fallot, what do we do when there's a TET spell, patient turns blue? Phenylephrine and volume are often administered. Single ventricle physiology, where in many cases the venous blood goes right into the pulmonary vasculature, the pulmonary artery, without a ventricle pumping, and is dependent upon the CVP to drive it into the pulmonary system. Hypoplastic left heart, there's some situations where if a patient is administered high concentrations of oxygen or hyperventilated, some very bad things can occur with hypoplastic left heart. We will go over those recommendations. Then there's some miscellaneous topics like SB prophylaxis, pulmonary hypertension, hypertrophic obstructive cardiomyopathy, the management of such, and post-cardiac transplant physiology. Congenital heart disease is present in almost 1% of all live births. And children who have congenital heart disease are more likely to require some type of non-cardiac surgical procedure, so you're going to be seeing those patients fairly commonly for surgeries other than heart surgeries. And the trend is early repair of these patients with congenital heart disease, often very shortly after birth, first few months of life, and often in the first year. So let's look at the first topic, which is anatomy of persistent fetal circulation. On the bottom left, you can see the normal circulation, and the bottom right, the persistent fetal circulation, in which a PFO is open and blood that's non-oxygenated or deoxygenated can go from the right atrium into the left atrium. And also you can see up here the PDA, if it opens up, can allow blood to go bidirectionally, either right to left or left to right, depending upon the vascular resistances in the systemic or pulmonary systems. And blood can go from the deoxygenated pulmonary artery into the aorta. So persistent fetal circulation, this can open up under certain conditions like hypoxia, hypothermia, hypercarbia, things that could occur in the perioperative period and result in an opening up of the ductus, PFO, and return to this persistent fetal circulatory state. When we talk about congenital heart disease pathophysiology, you can break it down into 3 major pathophysiologic states: things that increase pulmonary blood flow, things that decrease pulmonary blood flow, and lesions that obstruct flow. So let's start with lesions that increase pulmonary blood flow. And an example of this is a VSD, ventricular septal defect, an ASD, atrial septal defect, and a patent ductus arteriosus. Notice the letters are in pink, representing this as a pink lesion or acyanotic lesion. It's classically left to right shunt. In the picture in the top right is a VSD. The pressure is higher in the left than the right ventricle, blood going from the oxygenated left ventricle into the right ventricle. And this is a non-cyanotic lesion or pink lesion. And initially there's good oxygenation and ventilatory efficiency, but over time so much blood goes from the left ventricle into the right ventricle that there's a volume and or pressure overload to the pulmonary circulation. And if this is left unrepaired, the pulmonary circulation changes and pulmonary hypertension develops. And if the pulmonary pressures go up high enough, Eisenmengers can occur where left to right shunt then becomes a right to left shunt and the patient becomes cyanotic. Congestive heart failure can often occur from all the blood going from that left ventricle, flooding the right ventricle, flooding the pulmonary system. But initially, there's great pulmonary blood flow, in fact, too much pulmonary blood flow, good oxygenation, and ventilatory efficiency. The second major pathophysiologic category is a decreased pulmonary blood flow, and tetralogy of flow is a good example of that. Notice the color of the letters is blue. These are the cyanotic lesions that don't have good pulmonary blood flow. In the case of tetralogy of flow, in the picture up at the top right, you can see a VSD, an overriding aorta, overriding the septum, abnormally placed, RV outflow tract obstruction, and a big thick right ventricle. In this case, blood can flow left to right and right to left, and if the systemic vascular resistance drops, for example, blood can flow from the right ventricle to the left ventricle, bypassing the lungs, creating cyanosis. PaO2 can go down, the patient over time can get polycythemic, and since this is a shunt, you will see little change in P-AO2 and a blood gas as you go up on your FiO2. The third pathophysiologic major category is obstruction to flow. An example of this is aortic stenosis, pulmonary stenosis, and the stenosis can be supravalvular, above the valve, at the valve, or subvalvular. In adult patients, usually we just think of valvular aortic stenosis, but in congenital heart disease, the lesion can be above, below, or at the valve itself. And the heart says, I'm working pretty hard against the stenosis. This is a lot of work, and heart failure can occur, dysrhythmias. The cardiac output can be relatively fixed, trying to get blood through an obstruction, and the left ventricle can get very thick, and myocardial ischemia can even occur. So if we look at a breakdown of the congenital heart disease lesions in the pathophysiology, the top 10 are represented here with a ventricular septal defect at the top. 28% of all defects. Remember, this is mainly a left to right shunt. This is an acyanotic lesion and lots of pulmonary blood flow. ASD, about 10% of lesions. Again, blood flow tends to be left to right, and flooding of the pulmonary system and increased pulmonary blood flow. Patent ductus, again, a left to right acyanotic lesion, about 10% of total defects. Tetralogy of flow, about 10% of defects. This is a different pathophysiology, and that is, we pointed out in the previous slide, a right to left shunt when the SVR drops and pulmonary blood flow is reduced and cyanosis can occur. And then lesions that are obstructive, like pulmonary stenosis, aortic stenosis, coarctation of the aorta, and others listed here. Anesthetic management. One of the major points is balancing pulmonary vascular resistance and systemic vascular resistance. If you have a right to left shunt, as represented in the picture up at the top, you really want to avoid anything that increases pulmonary vascular resistance, because if pulmonary vascular resistance goes up, more blood is going to go from that right ventricle into the left ventricle, bypassing the lungs. So inhibit the rise in pulmonary vascular resistance. Opioids like fentanyl do that quite well. We want to avoid hypoxia, hypercarbia, high airway pressures, all things that increase pulmonary vascular resistance. When you inject an intravenous drug, it rapidly can cross from the right ventricle to the left ventricle to the brain, so there's a, quote, speedy IV induction, and theoretically a delayed inhalational induction of general anesthesia, which we'll show you in a graphic in the next 2 slides. Ketamine increases systemic vascular resistance and can decrease a right to left shunt, and so ketamine is theoretically beneficial in a patient, for example, who has tetralogy of Fallot by maintaining the systemic vascular resistance. This is showing anesthetic induction, FA-FI, or alveolar to inspired curve versus time, showing that in the case of a right to left shunt, the very bottom graphic, the rise in FA-FI of an inhaled agent is slowed with the cyanotic lesions, the blue ones, the right to left. Normally, a left to right shunt has very little effect on anesthetic induction of inhaled agents. So right to left, the cyanotic lesions can delay an inhalational induction, for example with sevoflurane. IV anesthetics, if you have a right to left shunt or a cyanotic lesion, the drug that's injected gets into the right ventricle, can cross over to the left ventricle, get to the brain a little bit faster. And so you can see the injection here represented at INJ, the little white box. In the blue being the cyanotic lesion, it gets faster into the brain, but it doesn't reach the same plasma concentration. So a little bit speedier induction potentially with an IV anesthetic in a patient with the cyanotic right to left shunt lesion. In left to right shunts, an example being the VSD, anything that decreases systemic vascular resistance will decrease the shunt. So if we turn on sevoflurane, turn on isoflurane, and drop the systemic vascular resistance, vasodilate, it's going to reduce the amount of blood that goes from the left to the right through the VSD, and more will go out into the systemic circulation. So often left to right shunts or acyanotic shunts will get less or better when you turn on an inhaled agent. Minimal effect on pharmacokinetics, the uptake of an inhaled agent like sevoflurane or an intravenously injected drug, and neuromuscular blockade is unaltered. So balancing SVR and PVR in patients with congenital heart disease is important. SVR being systemic vascular resistance, PVR being pulmonary vascular resistance. In the case of PVR, pulmonary vascular resistance, all the bad things make the pulmonary vascular resistance go up or constrict. Things like hypoxia and hypercarbia and acidosis and very high airway pressures and letting your patient get cold or giving high doses of vasoconstricting agents. Polycythemia makes it more viscous and raises resistance, and light anesthesia with high adrenergic output can raise PVR. So we can decrease pulmonary vascular resistance by providing more oxygen, hyperventilating the patient, making them alkalotic, giving them vasodilators, giving them fentanyl to block the adrenergic response to stimulation like laryngoscopy, and potentially avoiding nitric oxide, which can raise pulmonary vascular resistance. SVR, things that decrease SVR, deep volatile anesthetic depth. For example, turning up sevoflurane to several MAC will vasodilate a patient and decrease systemic vascular resistance. Vasodilating drugs like nitroprusside. And then things that increase SVR, light anesthesia, high adrenergic state, phenylephrine, stress, being cold and vasoconstricted, acidotic, polycythemia because of the increased viscosity, which increases resistance. So let's look at one of our first lesions, the patent ductus arteriosus. Here is shown an example of the ductus connecting the arch and the main pulmonary artery. Usually the ductus is right there at the takeoff of the left subclavian. The patient with a patent ductus arteriosus is often premature, but it usually closes within a day to 2 days in the term neonate. And in some lesions, keeping that ductus open is critical, and hypoplastic left heart is one of those where a patient will remain on prostaglandins to keep the ductus open until a surgical repair can be done. But it usually closes in term neonates within 1 to 2 days. In most cases, it's asymptomatic and is a left to right shunt. The aortic pressure is higher than the pulmonary artery pressure, so blood goes left to right from the aorta into the pulmonary artery. There's a continuous systolic and diastolic murmur. If there's a left to right shunt, which is characteristic, and it occurs over a long period of time, it floods the ventricle, the pulmonary artery gets a lot of blood. If pulmonary hypertension develops, right ventricular hypertrophy can occur. It doesn't always have to be just left to right. If pulmonary vascular resistance goes up, blood can go the opposite way and go right to left. So it can be bidirectional. We like to ligate the ductus before pulmonary hypertension develops, or the lung gets flooded with blood. And the picture at the bottom right is showing ligation of a ductus. And when that ductus is tied off, you should see a rise in diastolic pressure and ligation. For example, the blood pressure might be 60 systolic over 20 diastolic before ligation. The reason being is the ductus allows a low resistance runoff from the aorta into the pulmonary system. So the diastolic pressure is low, the pulse pressure is high, until you tie off that low resistance runoff, and the diastolic bumps up now to 60 over 40, for example. You can try to chemically ligate or close the ductus using a drug like indomethacin, which is a prostaglandin inhibitor. Remember, prostaglandins keep the ductus open. If you inhibit prostaglandins with indomethacin, you can potentially close it. If a patient has a patent ductus, a preductal arterial catheter would be a right radial, that is before the ductus, and would reflect what's going on in the head more than a left radial. In fact, if someone has a ductus open, we should likely put, if we want to know what's going on in the head with oxygenation, our SpO2 probe on the right hand or on the ear or on the forehead, not on the left hand or on the foot, which would not be considered preductal. Prostaglandins are used to keep the ductus open. In the graphic at the top, you can see that the prostaglandin pathway can be inhibited by aspirin and indomethacin. Indomethacin is the one that's usually used. And when prostaglandins are present, the ductus is open, and that's the prenatal condition. And after birth, in the neonatal condition here, when prostaglandins diminish, the ductus contracts and the shunt is reduced, and it closes over time. We want the ductus open in certain lesions. We mentioned hypoplastic left heart, transposition of the great vessels. We did not mention, but that's another one. Right-sided cyanotic congenital heart defects associated with reduced pulmonary blood flow, because blood flow can come then from the aorta into the main PA through the ductus, and we want to keep it open for those situations. Now, when you turn on a prostaglandin and administer it to a patient, neonates can go apneic, so they'll often remain intubated during the administration of prostaglandins. They also can get a temperature spike, which is often transient, and the blood pressure can drop sometimes. So those are complications of prostaglandins: apnea, hyperthermia, and hypotension. Let's look at tetralogy of flow now. The problem is these 4 lesions. 1, a ventricular septal defect. 2, the aorta, which is malpositioned and overlying the ventricular septum. 3, the RV outflow tract obstruction. And 4, the enlargement of the right ventricle. Those 4 lesions make up tetralogy of flow. The anesthetic management of tetralogy of flow means that if pulmonary vascular resistance goes up or systemic vascular resistance goes down, right to left shunting can occur. So let's look at, we want to manipulate PVR in the most favorable way. If SVR drops, right to left shunting can occur. If PVR goes up, right to left shunting can occur. So we want to decrease PVR, and we can do that with maintaining oxygen levels up, keeping the CO2 down, avoiding acidosis, using things like inhaled nitric oxide. remembering that things that increase pulmonary vascular resistance we want to avoid, like hypoxia, hypercarbia, acidosis, light anesthesia, and hypothermia. So in the case of a hypercyanotic spell in a patient with tetralogy, congenital heart disease lesions, or a TET spell, what is occurring is the patient is not getting enough pulmonary blood flow. For example, if you turned on nitroprusside or vasodilated someone significantly with an inhaled anesthetic, the SVR would drop, and across the ventricular septal defect, blood would preferentially go from the right heart to the left heart, past the lungs, and you would have a right to left shunt and desaturation. So dropping the SVR can result in a desaturation. Increasing pulmonary vascular resistance also increases the right to left shunt. Blood doesn't want to go out into the lung. It wants to go right to left from that right ventricle, which is trying to pump into the lung, but the pressures are so high there that it preferentially goes right to left into the left ventricle. So a crying patient, high peak airway pressures, hypoxia, hypercarbia, cold, acidosis, things that increase pulmonary vascular resistance, increase the right to left shunt, decreasing pulmonary blood flow, and the patient turns blue. So how do we treat a TET spell? Well, don't let the pulmonary vascular resistance go up, and don't let the SVR go down. So oftentimes we will treat it with phenylephrine first to keep the SVR up and reduce the right to left shunt. We also will want to drop the PVR, make sure we're oxygenating okay, increase the FiO2, hyperventilate the patient maybe. And in kids that are running around who have tetralogy unrepaired, what they will often do is they will stop what they're doing, they'll kneel down and kink off their femoral vessels, and what that does is raises systemic vascular resistance, reduces the right to left shunt, and they self-treat their TET spell. And we can do a knee chest position to kink off those femoral arteries, raise the systemic vascular resistance, and also treat that TET spell. But phenylephrine, volume, and occasionally beta blockers if the mechanism is the infundibular spasm, that is the outflow to the right ventricle, the muscle is spasming, and beta blockers can treat that. Classically, phenylephrine and volume are what we use though, however. So what do we do to treat tetralogy of flow? Initially, they may undergo what's called a modified Blalock-Taussig shunt, and this is what's shown here in white. In this case, a small, often 3.5 to 4 millimeter Gore-Tex graft is placed between the arterial systems, such as the right subclavian artery, into the right pulmonary artery, and this allows blood under systemic pressure to get into the pulmonary artery, which wasn't getting enough blood because notice the pulmonary atresia here in this case. So raising pulmonary blood flow with a modified Blalock-Taussig shunt can be done initially. Now, if someone had a BT shunt and then come for a more definitive repair, the BT shunt is taken down and is removed. A patch can be placed between the right and left ventricle to close off the VSD. Enlargement of the pulmonary artery can be done with a patch. And now, in this case, all venous blood goes to the right heart and then into the lung through the pulmonary artery, which is enlarged, and there is no right to left shunting. Tricuspid atresia is another example of a patient, in this case, with a single ventricle. Here, they just have a left ventricle, the right ventricle is underdeveloped, blood is communicating through the interatrial septum with a hole in it in this case. We need to get blood to the pulmonary artery, and again, a Blalock-Taussig shunt, BT, modified BT shunt can be done to increase pulmonary blood flow. Now, the thing about a BT shunt is that blood is going into the pulmonary artery under systemic pressure, so you do not want to leave this in place for a long period of time. If it was left in place and the pulmonary artery saw these high pressures for a long period of time, it could develop changes, peripheral vascular resistance go up, and pulmonary hypertension develop. So a BT shunt is a palliative or temporary procedure to raise pulmonary blood flow. In the case of tricuspid atresia or single ventricle, one of the next stages after a BT shunt is a Glenn procedure or bidirectional Glenn shunt. And in this case, what has been done is the SVC blood comes down, and the SVC is connected to the pulmonary artery, so venous blood from the head goes straight into the pulmonary artery, while venous blood from the body comes into the right heart, communicates over to the left atrium, and goes out into the body. So you can see that IVC blood isn't even going to the lung, and this is a huge shunt. Saturations are often in the 70% range or so, and that's the way it's supposed to be, because now we want venous blood going to the pulmonary system as the pulmonary system develops and the pulmonary vascular resistance decreases as the child grows. So the second stage is a bidirectional Glenn, and you expect this patient to be desaturated. Fontan completion for a single ventricle is represented here, in that now not only is the superior vena cava connected to the pulmonary artery directly, but the IVC is connected to the pulmonary artery directly. And so all venous blood is going into the pulmonary artery, and then pulmonary artery blood that becomes oxygenated comes into the pulmonary veins to the left atrium, out the left ventricle to the body, oxygenated state, and this patient should have a normal saturation or near normal saturation. The problem with this is that there is no ventricle pumping blood into the pulmonary artery, and the driving force for blood to go into the pulmonary artery is CVP. So you could see that if this patient got a little bit dehydrated, or you got behind on volume, a single ventricle Fontan physiology patient requires a CVP, adequate CVP, to drive blood into the pulmonary artery because there's not a ventricle. Many of these patients have a little artificial hole or fenestration made in this conduit, such that if the pressure builds up too high in the venous system, it can pop off and blood can go into the atria here and not allow the venous pressures to get too high, but it does so at the cost of basically a right to left shunt and desaturation. Hypoplastic left heart is a very, very bad cardiac lesion, and it's represented here in the fact that the left heart does not develop properly. Notice not only the left heart doesn't develop properly, but the first part of the aorta. The whole ascending aorta here is atretic, the arch is atretic. How is blood getting to the head vessels? How is blood getting to the coronary arteries? And you can see in this case that the ductus becomes extremely important to be open and providing the blood that goes from the pulmonary artery up through the ductus into the arch to the head vessels and also down into the coronary arteries. And if this ductus closes, this patient will die. This patient is going to be on prostaglandins prior to surgery, and those prostaglandins should never be stopped before surgical repair. So hypoplastic left heart, maldeveloped left ventricle, maldeveloped ascending aorta, and arch. And there's multiple variations on this, but remember the ductus needs to remain open. So there's a hypoplastic ascending aorta, arch, and LV. Some questions to think about. Why are these patients, most of them on room air, or even less than 21% oxygen, subambient? They may be on 18% oxygen, for example. Well, if we go back to the lesion, you can see that if the pulmonary artery dilated, i.e. pulmonary vascular resistance goes down in response to lots of oxygen, where would blood go? It would go out to the pulmonary artery rather than through the ductus. So we don't want blood pouring into the lung and not going out into the systemic circulation. In fact, if you give a hypoplastic left heart patient lots of oxygen, what will happen is your saturation will look great, but your first blood gas will come back oftentimes very acidotic because blood is not going systemically and perfusing the tissues. It's just going into the lung and flooding it. So we don't want to give a lot of oxygen. The next question is, why is it important not to hyperventilate them? And if we go back to that picture again, remembering that hyperventilation and dropping the CO2 level results in pulmonary vasodilation, or a decrease in pulmonary vascular resistance. Again, if we hyperventilate the patient, PVR goes down, blood goes out the pulmonary artery and says, I'm going to go preferentially to the lowest resistance, and if that's the lung, it goes to the lung, and your saturation initially looks good, but not good systemic blood flow, and not good blood flow to the arch vessels and to the coronary arteries. So we don't want to hyperventilate. We want to keep their FiO2 low, and they obviously need that ductus open to keep blood going to the systemic circulation. So these patients often undergo a staged reconstructive procedure called a Norwood procedure, and it's 3 stages. Stage 1, 2, and 3 are listed here. At the first stage, there's a big surgery done in which an atrial septectomy for mixing is performed, anastomosis proximal pulmonary artery to the aorta, homograft augmentation of the aorta and arch, and oftentimes aortopulmonary RV to pulmonary shunt called a Sano shunt. Stage 2 is a bidirectional Glenn, and then stage 3 is that Fontan that we previously talked about in single ventricle physiology. Hypoplastic left heart is single ventricle physiology, in which the right ventricle is being made to do the work of the left ventricle because it didn't develop. And so we end up with a Fontan physiology in the patient with hypoplastic left heart. Some institutions transplant these patients early. So balancing SVR and PVR in a patient with HLHS, or hypoplastic left heart syndrome, remember that if there was a high FiO2 given to this patient, it would decrease the pulmonary vascular resistance, flood the lung, have a good initial saturation, but poor perfusion of the systemic vasculature. We do not want to provide high FiO2 or hyperventilate these hypoplastic left heart patients. SBE prophylaxis. Some new conditions associated with the highest risk of adverse outcome from endocarditis have been identified. And if we just look at the American Heart Association recommendations, you can see that under congenital heart disease, if you have an unrepaired cyanotic congenital heart disease, including palliative shunts and conduits, there's artificial materials in the heart, or there's an unrepaired cyanotic lesion, you should prophylax these patients. If they've had a completely repaired congenital heart defect with some prosthetic material or device, whether surgically or in the cath lab, basically you should prophylax them during the first 6 months after the procedure. For example, if you put a close of VSD and the materials present there, that prosthetic material, it's at risk for bacteria getting on it and growing, especially in the first 6 months after the procedure. And if they've had a repaired congenital heart disease, but you know what, there's residual defects. For example, you closed a VSD, but there's a residual defect around the site where the patch was put in place. Think about those patients having prophylaxis needs also. So if we summarize some of the overall basic anesthetic considerations for management of patients with congenital heart disease: 1, avoid air emboli. Make sure your IVs don't have any air in it, because that air can go through your IV into the right heart, cross into the left heart very easily in the case of defects in the chambers of the hearts, and get to down the coronaries up to the head, for example. Bacterial endocarditis prophylaxis should be thought about frequently. Where are you going to put your monitors and monitoring sites? Remember, we talked about preductal A-lines and preductal pulse oximeter placements being on the right hand or the ear to reflect what is actually going on in the head. And balancing systemic vascular resistance and pulmonary vascular resistance, remembering that things that decrease pulmonary vascular resistance is lots of oxygen, dropping the CO2, blunting adrenergic response such as light anesthesia, avoiding hypothermia, And things that can change SVR classically in the operating room setting are inhaled anesthetics. We turn them on and they vasodilate. And think about what we're doing and how we're balancing SVR and PVR in these patients where blood can go one way or the other depending upon vascular resistance. And we base our anesthetic management on the major pathophysiology of the patient. Do they have right to left shunt, such as the Tetralogy patient, left to right shunt, like a VSD patient, or congestive heart failure patient with an obstructive lesion, like a subaortic stenosis, where the ventricle is thickened and pumping against a resistance and may even be failing. In the right to left shunt, remember that if we drop systemic vascular resistance, there's going to be more right to left shunt. We want to maintain that in the Tetralogy patient. The left to right shunt is flooding the right ventricle and the pulmonary system. And the congestive heart failure patient, we need to maintain heart function as it pumps against an obstruction. This ends the podcast, which is pre-class, our flipped classroom, where we'll talk more about this topic in an active learning manner. I hope you have a wonderful day.